time for a few questions.
Yes, sir.
Jeff Bush with Becton Dickinson, and I wanted to go back to your active model on effectiveness information and ask you, as it relates to what is in the legislation, specifically the value-based purchasing provisions that will obviously only impact, at least immediately or in the immediate future, the inpatient payment system to hospitals. But I wonder generally what your perspective is on that and whether that's applicable. I think it's probably applicable, but how effective it may be. And then, you know, we know the cap on that from the legislation is going to be about a 2% payment impact, and is that sufficient? And then just kind of follow up to that, what is, if that's not the right number, what is or what's close to, do you think, the ultimate clearinghouse incentive?
Yeah, well, so I've said a lot of critical things about the legislation. I think actually it is a good idea to start with hospitals. They do seem much more responsive to incentives than physicians do. The part, though, that I think still remains to be seen is how this will be translated into physician behavior. It's not, again, kind of in the hierarchy I was going through. I think it would work immediately and effectively in things like Mayo, Geisinger, Kaiser, and so forth. It could be made to work, although I think there would be some wailing and gnashing of teeth in academic medical centers where the medical staff is largely salaried. I anticipate a lot of issues in the more standard community hospital setting where the physicians treating the patients are not salaried employees of the hospital. But, you know, as a first step, it's a pretty reasonable thing to try. You know, as I said in my opening remarks, give it a shot.
Is that because you believe that hospitals are more motivated by money and physicians may be more motivated by taking care of their patients? Because the question, you know, I have a talk that I give called comparative evidence-based medicine, whose evidence, whose medicine, and we can probably all agree that if you have a burst appendix, you probably should have that taken care of. The reality, even the Dartmouth people find, surprise, surprise, 100% of people that have, actually more like 110% of people that come in with hot appendices or even moderately hot appendices get them removed. The issue is if you're looking at a patient that doesn't quite fit the meta-analysis and somebody says, geez, we'll pay you a little extra if you follow this guideline, that gets into a bit of a difficult problem for doctors. Hospitals, as proven by the DRG experiment, have absolutely no problem doing that.
Well, I think the answer to your question, Bob, is yes. I think doctors do care about patients, although I think they also care about some things that are noble, like doing what they think is the right thing, and some things that are less noble, like why should I have to change? I think I'm practicing okay. I guess my answer was more of an empirical observation. I suppose if you could get your doctors to change behavior, you must have been overpaying them in the hospital in the first place. But I think there's probably enough slack there that for the relatively modest thing that we're talking about here, hospitals could probably produce changes in behavior. There's still the issue of, well, when the dust clears, will it have been a good thing or a bad thing? But at least they could do it.
Dr. Pauly, there seems to be a presumption in a lot of this discussion, both at this meeting and in the other one that InHealth held before, that there is no real good comparative research out there amongst the large insurance companies. And I'm wondering, because I used to run one of those, we studied a lot of that. And we had a lot of data. It may have been imperfect, but we were very focused on the idea of how do we reduce costs and where is there an opportunity to do that without, you know, pay attention to the outcomes. Has anyone done some research to understand the state of the art amongst the large insurance companies? Because these are,
yeah, well, that's
my old company, Humana, is a $30 billion company, and they can afford to spend a lot of money on this stuff because there's so much at stake. And there seems a presumption that only these independent panels know anything about it.
Yeah, no, that's actually an interesting point. I mean, you're certainly, what I know is what you know, or, although probably less, but it is that insurers have put a lot of effort into themselves studying, insofar as they can with their data, the evidence on comparative effectiveness of things that they pay for. Oftentimes, of course, it comes up with the conclusion, as I said, that things are never totally useless, and it's a matter of deciding where, and when you can, you try to implement those things. The question then is, the sort of fundamental question is, well, why did the government have to get into the act? There is a theoretical proposition that no individual insurer would carry this effort as far as is socially optimal, because discovering what works and what doesn't is like a public good, and I'm certainly sympathetic with that. But I mean, you make a good point. It would be interesting to see, you know, kind of what's at the margin. Where did insurers stop doing comparative effectiveness research? I don't know if Roger's still here or not, and whether that was looked at the IOM study. Where did they stop doing comparative effectiveness research? What would have been the next study they would have done, and how valuable would that have been? A lot of the debate, though, I think, is not so much about the presence or absence of information, but the use of information, and whether it's, and this has partly as well to do with its provenance, whether it comes from a source that can be fashioned either into a carrot or a stick. And to some extent, insurers are sort of their own worst enemies there. And so the thought is, well, maybe if it comes from a dispassionate source, it'll be less skeptically received.
It comes back to no one trusts the insurer.
Yeah, that's kind of what I'm saying, in a euphemistic way. And then the other reaction, I didn't get into this, but I think it is many insurers' reaction. They'd like the government to do this, and they'd like Medicare to do it first to give them cover. Then they'll do it. That's probably, some of them are braver, but that may be the line of least resistance.